regardless of their ability to pay by 2030. We're, of course, talking about universal health coverage and the first UHC high-level meeting that took place in New York in September of 2019. Over the years, UHC has been described as one of the most powerful concepts that public health has to offer and a key instrument and goal to enhancing sustainable development. And there are three important dimensions of UHC: service coverage, the range of package of services according to needs, referred to often as the benefit package that governments are providing; financial coverage, so protecting people from the financial consequences of paying for health services out of their own pockets; and population coverage, so ensuring that the whole population is covered by these health services and essentially that no one is getting left behind. While countries have been making progress on universal health coverage over the last 4 years, since that first high-level meeting, through a range of health reforms as well as political leadership, the overall scorecard from the recent UHC 2030 status report very clearly said that globally we're off track and that implementation has really been lagging. And one of the major challenges facing countries in their progressive realization of universal health coverage is the global burden of non-communicable diseases, which has very serious implications and impacts across all three dimensions of UHC. For example, in most countries, current service coverage and access to NCD services remains significantly inadequate. For example, half of adults living with diabetes remain undiagnosed and are unable to access the insulin that they need. In terms of financial protection and coverage, NCDs are essentially a big outlier. Unlike many infectious diseases where treatments are covered by public health insurance, treatment free of charge, people living with NCDs are often shouldering the cost. And in terms of population coverage, NCDs disproportionately impact people from low socioeconomic status, as well as marginalized communities. So the need to ensure UHC is universal and is focusing on the inequities is very, very clear. So the upcoming second UN high-level meeting on universal health coverage, which is taking place just this September in 2023, alongside two other health high-level meetings on PPPR as well as TB, presents a crucial opportunity to address these challenges head-on and advance efforts to prevent and treat non-communicable diseases. And also critically, to ensure that UHC is really a catalyst for cooperation across the global health community. I'm really pleased to announce that in the lead up to this second UHC high-level meeting, the NCD Alliance's annual campaign, the Global Week for Action on NCDs, will be running from the 14th to the 21st of September, and will focus on the theme of bridging the care gap. And with this campaign, we hope to mobilise the community around the UHC high-level meeting and ensure it's a tipping point politically and call for urgent action to ensure that every person has the right to access to essential and quality NCD care without the risk of financial hardship and poverty. So I'd like to take this opportunity to share with you our short campaign video for this year's Global Week for Action. I hope. Thanks very much. And I hope everyone gets involved in the Global Week for Action this year. So getting back to today's event, we've got a great lineup of speakers, both digitally and in person. And we're going to be organising the event across two panels. The first panel is on the topic of governments putting people living with NCDs at the centre of universal health coverage. We'll be hearing from 4 government representatives, all joining virtually, from the Cooperative Republic of Guyana, the Republic of Rwanda, the Republic of Slovenia, and the Kingdom of Thailand. In the second panel, we will explore the question of how can we work towards progressive realization of universal health coverage for people living with NCDs. And for that, we're joined by panelists from the World Health Organization, OECD, UHC 2030, and the Lived Experience Advocate. Before we start, as Patrick mentioned at the beginning, we'll be inviting questions for both panels throughout this event. So we encourage those of you in the room, when we get to the Q&A, to raise your hand, and I'll try and get to as many people as possible. And for those online, to be submitting your questions at any point within the Q&A function as we go. And we'll be collating the questions and presenting them to the panelists in the Q&A segment. So with that, let's jump to our first panel. And I'm going to be posing the same 2 questions to each of our government representatives. Those 2 questions are, number 1, why the inclusion of the prevention and care needs of people living with NCDs is important to achieving universal health coverage in your country. And number 2, what has your country done to include NCDs in your country's UHC response and benefit packages? And it's my great pleasure to hand over to our first panelist, Dr. Leslie Ramsamy, who is the advisor to the Minister of Health from the Cooperative Republic of Guyana, who is joining us virtually. And just to point out that Guyana is one of the 2 co-facilitators for the UHC high-level meeting this September. Dr. Ramsamy, over to you.
Thank you very much. And good morning again, everyone. Guyana is honored to be co-hosting this event. I think on the first question, the answer is very simple. We cannot afford not to integrate NCDs into the UHC. The truth is that without integrating interventions for NCDs across the continuum of care and across the continuum of the healthcare system, there is no UHC. Without UHC itself, it is impossible to provide equitable NCD care for the entire population. It is impossible to avoid catastrophic expenses and therefore impossible to prevent people falling into poverty. In our case, in Guyana, 74% of all deaths in Guyana presently are accounted for by the NCDs. Almost 30% of all premature deaths in Guyana are NCD deaths. More than 38% of deaths due to NCDs are premature deaths. More than 75% of Guyana's health sector's budget is presently allocated to dealing with the NCDs. And so we have every reason to integrate the NCDs into UHC, besides the reality of Guyana having a major non-communicable chronic disease problem that affects overall health of our people, that affect the people living disability-free lives. We must honor our obligation. As was said earlier, in 2021, we made a commitment for UHC. But going back to 2011, at the high-level meeting of the UN, and year after year since then, we have signed on an obligation to introduce NCD services for our people across the continuum. And therefore, it is critical. It is critical that not only do we effectively implement the UHC model of care, but that we introduce at the primary health care level, from promotion to prevention, treatment and care, palliative care, NCD services. cardiovascular diseases, respiratory diseases, cancer account for the vast majority of our hospitalization right now. If you take kidney disease, when you look at our dialysis rate, it's very low compared to global statistics. And that is because we are not identifying our people early enough. So those silent killers like hypertension and so kidney diseases are killing people, making them extremely sick, filling up our hospitals because we are not identifying them early enough. And so these are the critical reasons why I believe that we need to ensure that NCDs are fully integrated into the primary healthcare system. And if we are, as a country, Guyana specifically, I'm referring to, going to meet our obligation under the SDGs, whether it's 3.4, 3.8, 3.5, 3A, 11.6, all of these obligations that we have under the SDGs to make life better for our people in our country, we must integrate NCD at the center of the UHC. And in Guyana's case, when we speak of NCD, we also mean the mental health. One last point here, taking care of vulnerable population must be a special obligation of the country, of the government, and of the system. If you look at vulnerable population, about 15 to 18% of Guyana's pregnant women are gestational diabetes. If you look at HIV, they have 2 to 3 times the rate for some of the NCDs. You're looking at TB, there are higher rates for the NCDs. And then if you look at COVID-19 and the convergence of an infectious disease with the chronic diseases, you see the need to have NCDs integrated across the continuum of care. We will be dealing with long COVID, and dealing with long COVID means we're dealing with a chronic disease. So I think we have many, many reasons. We will not be able to reach our goals for HIV by 2030, for sure, if we do not integrate NCDs across the continuum of care. So I think these are the reasons why countries, certainly why Guyana, must do a more effective job of integrating NCDs into the primary healthcare system and be able to say that we have effectively implemented a universal healthcare system in our country to meet everyone. No one must be left behind. That would be my answer to the first question.
Thank you very much, Dr. Ramsamy, for underscoring the clear evidence for integrating NCDs, and particularly emphasising the importance of the primary healthcare system and the importance of the continuum of care from health promotion all the way to palliation. I'm going to be moving on to our second speaker, and we'll obviously have time for Q&A at the end of this panel. So I'll now move on to Dr. Francois Uwinkindi, who is the manager of the NCDs division of the Rwanda Biomedical Centre of the Ministry of Health, which is the implementation arm of the Ministry of Health in Rwanda. I actually had the pleasure of being in Kigali last week and met with Dr. Francois and the Minister of Health. And there's absolutely no doubt that Rwanda is a real leader and trailblazer on universal health coverage and NCDs within the region as well as globally. And we're very proud to be holding our 4th Global NCD Alliance Forum in Rwanda in October of 2024. So, Dr. Francois, please, over to you to share with us Rwanda's UHC journey and how you've done it and how NCDs are incorporated. Over to you.
Yeah, thank you so much, Kathy. And as you said, we're very happy to have you. I think just 2 weeks in Rwanda, and also we are very ready to host the Global NCD Forum. So, and as you introduced me, so I'm Dr. Francois Uwinkindi, and I do work for Rwanda Biomedical Center, which is the implementing entity of Rwanda Ministry of Health. And in the Rwanda Biomedical Center, I'm in charge of non-communicable diseases program. It's a program that has got four units. The first one is on cardiovascular diseases. The second unit is dealing with diabetes, chronic respiratory diseases, but also other metabolic diseases. And the fourth unit is about cancer diseases, which is also a very important one that we have. And also the fourth one is on injuries and disabilities. So these are the four main units of programs that make our non-communicable disease program. So briefly, and going directly to the question, and I think I would say it's a must to integrate non-communicable disease prevention and the treatment into UHC, because if you look at where we are in our countries, I mean, in our developing countries, we are really facing a double burden of diseases. I mean, we are still dealing with infectious diseases, but also the burden of non-communicable disease is increasing very quickly. And even if you look at where we are now, non-communicable diseases are taking over these infectious diseases. So we need really to do something. So, and as a country, we are happy to have a people-centered government, a government that is putting the lives of our people first. So if you look at really what we've done, if I can take an example, like 10 years back, is that and even this initiative of putting in place a dedicated division dealing with non-communicable diseases that is in charge of really coordinating all interventions related to disease prevention and control in the country. This is really the first step. But also, and I think if you look at back in, let's say, in 2015, NCD management was mainly, provided at the tertiary care done by those specialists. And can you imagine really 5 hospitals? We have 5 teaching hospitals, treating, everyone, all our people in need of NCD services. It was not possible. And even the cost of transportation was very much higher than really the cost of health services itself. And then even people were not really being lost for because, you are spending around $20 every month to come to the clinic. So this was not possible. So I think in 2017, we took a decision to decentralize the care of NCDs, these severe NCDs, and make sure that really we are really not only remaining with those teaching hospitals treating NCDs, but also decentralizing NCD management at the district hospitals. Doing so, we trained really a critical number of nurses in this process that we've called task sharing or task shifting to make sure that, of course, most of our countries are having a shortage of doctors. So, but we have really a good number of nurses. So it's really possible to train them to make sure that they are trained. You give them tools, you give them, and also you continue doing a regular mentorship and they can really provide a good care to our patients with NCDs. I remember in 2015, we had around, like 7,000 people with NCDs being treated in a different, in our teaching hospitals. But after doing the decentralization and also task sharing in 2017, and I think after 2 years, we counted around 50,000, patients with NCDs being followed in different NCD clinics. But as we speak now, we do have around 200 patients with NCD, and the majority of them are with, cardiovascular diseases. So this is to show that really patients are there, but how do we make sure that really we put services closer to where our patients live? So we decentralize first to district hospitals, and then now we have, I think, the last 2 years, we even also put services at the level of health centers. Where we have trained people, we have also dedicated clinics, NCD clinics that are treating our patients with NCDs. Following the chronic care model, not really, because these are patients that will be in the system for many years. So we should make sure that really services are friendly, but also services are of quality. So these are things that we are doing, but also not only focusing on the geographic accessibility, but also focus on financial accessibility. We are very happy to say that now all these essential NCD services, essential NCD diagnostics, but also medicines are covered by our health insurances, including also our community-based health insurance that is covering almost like 98% of our people. So now people are now really accessing all these medications, using their community health insurance, and then at the facilities, they're only paying 10%. But if you go to the health center, where like 80% of our people, if any cities now are being treated, people are now really paying around 2 cents if you convert it into dollars. So this is really helping our patients, but also patients are no longer really paying, a lot of cost for transportation, because now from their homes to the health centers, now on average, they can now walk 30 minutes. So this is really, it's really helping our patients, it's increasing the adherence, but also we can now even see treatment outcomes. Just if you look at maybe how the percentage of our people that are controlled, if you take diabetes and hypertension, the numbers are high. So we know that this is not really, of course, it's a journey that we have started, and we are not yet there. We still have a long way to go, because as other countries, we are still having, people coming late, so coming with complications. So to address this issue, so now recently we have now made a reform for our community health workers. We have now included NCD's awareness, NCD screening, but also linkage to care. So we've started this in a few districts, and I think the plan is really to scale up into other facilities, because we've seen that, if we wait people to come at the facility to do checkup, to do maybe to request for those screening services, they will delay. But if you can provide services closer to where they live by those community health workers, because we've seen that really these are things that will pay off in the near future, so that you can have really people early and then be able to treat them on time. That's when we can really be able to reduce this premature mortality due to these non-communicable diseases. But of course, we are doing this in collaboration with other sectors, with other partners. You know that, you cannot tackle NCDs alone as the Ministry of Health. We need to really have it as take it as a multi-sectorial issue. So bringing in on board other sectors, other institutions, but also civil society organizations, that's the only way you can really make sure that you are putting in place sustainable services. So briefly, I can say that Rwanda has done a lot in terms of decentralizing, in terms of integrating non-communicable diseases into UHC, but we still have a long journey to make sure that we can also increase the community coverage. If you look at the prevalence now, if you take an example of hypertension, where we have a prevalence of 16%, and if you take the number of people that with hypertension that we have into different clinics, into different facilities, so the coverage is zero. It's around 15%. And we think that now putting the screening of NCDs into the community will help us to increase this coverage and make sure that really we are no longer having people dying just with stroke, with all these other complications. And yet these are things that we should have discovered early and also be able to provide the treatment on time. But of course, without forgetting, the prevention for all these major NCD risk factors. So this is really what we are doing, and I can pause here and probably more information during the Q&A session time. And happy to continue sharing, but also to learn from others. Thank you.
Thank you very much, Francois. And it really is an amazing success story of what's the progress that's taken place in Rwanda over the last couple of decades around universal health coverage. And as you say, the importance of kind of decentralization, task shifting, as well as taking care to communities to make it easier in terms of travel and access, essentially. So now we'll move from Rwanda to Slovenia, and we'll now hear from the representative of Slovenia, Dr. Kirsten Vesna-Petric, who is the head of the Office for Cooperation with WHO from the Ministry of Health of the Republic of Slovenia, and who also chaired the WHO Executive Board in January, where UHC was obviously discussed. So over to you, Dr. Petric, in terms of the experience of Slovenia on universal health coverage.
Thank you very much, and good morning, good evening, wherever you are, to everybody. Slovenia is one of those countries where in legislative terms, we ensure universal health coverage to all citizens, and statistically, inequities in health are among the lowest in the world. We have a strong network of primary healthcare centers that offer access to family physicians, pediatricians, and gynecologists with no referral. We consider universal health coverage very broadly. Every citizen should have access to diagnostic services and treatments, including to medicines. More or less, everybody is covered by compulsory and voluntary insurance or by the budget. As an essential part of universal health coverage, we also understand access to preventive checkups for assessing risk factors and detecting early stages of NCDs. And access to organized cancer screening is also included. While being lucky in having a very good basis, we have learned that ensuring access in legal terms is not enough. This is in particular so in domain of prevention of NCDs, where people are not urged by their health status to access services that are available to them and even free of charge. In recent decades, Slovenia has deliberately invested in promoting preventive services with public campaigns and in ensuring they are accessible to all, including those most vulnerable, often hidden and difficult to reach populations. Let me share two examples where we first failed and then improved. Introducing organized screening for colon cancer is a very illustrative example. We invested a lot in inviting citizens at certain age to the screening by letters and promoted the program in different ways. Very soon, it has been realized that women access these services much better than men. Investing in campaigns that were targeting male population in a different way has contributed to the fact that the response rate now is around 70% for both genders. Another example in the introduction of health promotion is the introduction of health promotion centers, where citizens can get free of charge smoking cessation, nutrition and obesity counseling, and other preventive services. These centers were introduced in almost all primary healthcare centers and are employing nurses, but also psychologists, dietitians, and kinesiologists. By carefully monitoring participation in various programs for years, we have realized that these services have not been attended well enough by those most in need, from lower social groups, unemployed, with less education, and again, men. We have recognized that the only solution would be to reach out of health facilities into community, involve non-governmental organizations, social services, and school to identify the needs of these groups first, and then help us in working in health to best address their needs. By investing in this regard, we can now monitor improvements. Still, further investments in health literacy would be needed. I want to be very clear that these improvements in access would not be possible without carefully monitoring and evaluating programs and services when introduced. I also must accentuate that additional investments were needed by the state for the campaigns, for training of professionals, for the involvement of NGOs also, and other stakeholders. And finally, our progress was very much supported by collaboration with WHO, the key organization in health, in terms of increasing capacity of our own professionals by ensuring their participation in WHO networks and trainings, by organizing together policy dialogues, and by sharing good practices from other countries. The progress in my country has been good, but could even be better if there would be more political will to fully implement the best buys in, for example, tobacco control and alcohol policy. Let me conclude, we are convinced that ensuring good progress in universal health coverage globally, as we understand it in my country, and reaching the SDGs, we should aim for global action based on solidarity principle and focusing on all populations, even those in crisis, war areas, where the only way to leave nobody behind is working hand in hand with NGOs. We see WHO as a key organization that needs adequate resources in the area of NCDs to be able to provide appropriate technical support to countries, enable innovation, involve NGOs in a best possible way, and ensure good practice exchange and monitoring and reporting of progress. Thank you very much.
Thank you so much, Dr. Petrovic, for that intervention. And I think you're bringing up some really important points there around the importance of prevention and health promotion within universal health coverage, which often gets missed and forgotten, as well as the need for constant monitoring and evaluation through effective surveillance systems within countries, as well as global cooperation and the importance of the best buys, which are obviously being discussed at the World Health Assembly and being updated in May. So thank you so much for that. Finally, for this panel, we'll hear from our representative from Thailand, Mrs. Waraporn Suwanwala, who has shared a pre-recorded intervention with us. So now let's listen to Thailand's progress and experience of UHC and NCDs.
Thank you, moderator. Good morning, good afternoon, and good evening to all panelists and delegations at the event and virtual platform. First of all, on behalf of the National Health Security Office, or NHSO in Thailand, I would like to convey our highly appreciation to the co-hosting organization, inviting NHSO and myself to join this valuable platform. And I would apologize that I cannot join the event myself in Geneva, but I am very happy to share you Thailand experience on NCD. If you are looking for more information, please visit NHSO website at www.nhso.go.th. I have posted the QR code at the end of the presentation. Before getting into the detail to answer the question from the moderators, I would like to briefly introduce Thailand health insurance system. So, according to USC Cube, the entire Thai citizens are covered under three main public health insurance schemes. First of all, Civil Servant Medical Benefit Scheme or CSMBS, the coverage is at 9%, while another 19% are covered by Social Health Insurance or HSI, and the rest is Universal Coverage Scheme or UCS, which cover more than 70% beneficially. The benefit package covers all essential services from health promotion and disease prevention, immunization, mother and child health, from simple illness to high technology and high cost services like that ART, RRTs, cancer treatment, major surgery, and organ transplant. All services provide essentially free at point of services, according to rule and regulations. Out-of-pocket expenditure as percentage of current health expenditure fell gradually from 34% in year 2000 to 8.7% in 2019. Distinguished delegates, to answer the question that why the inclusion of prevention and care needs of people living with NCD is important to achieve UHC. The data from Prevention and Control NCD in Thailand, the case for investment, revealed that NCD are the #1 killer in Thailand with these top 4 main NCD. First, cancer. Second, cardiovascular diseases. Third, diabetes. And the last one, chronic obstructive pulmonary disease. It causing estimate 400,000 deaths each year, or 74% of all deaths in the country. To answer to the next question, what has done to include NCD prevention and care in Thailand UHC health benefit package? In regarding to UCS, which is the biggest public health scheme in Thailand, the mechanism that we use for NCD prevention and care in Thailand consist of Firstly, the legislation for USC is the center of implementation. In accordance with the National Health Security Act enacted by and with the advice and consent of the Assembly of the People Representative, is one of the core components to achieve USC in Thailand since 2002. The Act contains various provisions, including Article 3, that outline the definition of health services under the UCS, which includes comprehensive health benefit package. Moreover, the National Health Security Board have an authority to make decisions on this necessary matter and announce the concrete order to beneficiary health providers as well as relevant stakeholders. Secondly, provider payment method. The NHSO has designed the provider payment method to ensure access to care and effective budget management. Thirdly, continually development. We continue developing of NCD benefit package due to a new health technology available in the market and a change of need. Lastly, the result. This means access to care, quality of care would be monitored periodically to assure standard and quality of healthcare services. Even though that Thailand has well prepared for NCD prevention, but NCD is now tend to be of long duration and are the result of the combination of genetic, physiological, socio-economic, environmental, and behavioral factors. So the challenge remains. We found that finding the country context optimal interventions for using NCD or any health crisis as a window of opportunities to moving forward USC. We may need more investment in NCD prevention and control, including financial, health workforce, and health technology. And the last one, we think that an engagement of multi-sectors, including public and individual, to tackle these health problem is needed. Thank you for your attention. I will give the floor back to the moderator. Thank you.
Thank you very much, Waraporn, for sharing the context of NCDs within universal health coverage within Thailand, another fantastic leader within the UHC global response. We're going to have I've got one question for each of our live panelists, and I'd like to ask each of them to try and be as brief as possible because we're running slightly over time. But I'd like to come first to Dr. Ramsamy to have an opportunity to answer that second question around how Guyana is including NCDs within universal health coverage. I'd then like to ask Francoise a question that we've received from the online chat about the community health worker, for how the community health workers are being trained within Rwanda, and what screening they're able to carry out at the community level, which is a question we've received from Margaret B. online. And Kirsten, I'd like to ask you, with 6 months until the UHC high-level meeting, what would you say your top 2 to 3 priorities are from an NCD perspective for the UHC political declaration? So let's first go to Dr. Ramsamy.
Thank you very much. Well, let me say this, that if we're going to introduce NCDs in the primary healthcare system, we need to define our package of service. So in 2021, we revised our package of service that we provide across the continuum. And so at the moment, we are implementing a package of service that goes from promotion, prevention, treatment and care, and palliative care from primary level all the way to the National Referral Hospital. As part of that, we have introduced HEARTS, which is a cardiovascular primary health care program, Heart Plus D, which is the cardiovascular plus diabetes. And we are presently at about 40% of our health facility fully implementing Hearts Plus D. We hope that by 2025, we will be at 100%. And as an example with diabetes, HbA1c has become the guideline for diagnosing diabetes, which is now available from primary health care. We hope that by the end of this year, most of our primary health care facilities would have the capacity to offer HbA1c. And there's a list of other things, but I'm aware of time. But I do want to mention this. This year, we are beginning a vision care program in our schools where every child from nursery to secondary school will be screened for vision, and those who require glasses to correct their vision will be provided that free of charge. The same thing for dental caries. In our schools, we are introducing oral health in our schools and screening all of our children. And one last thing, respiratory disease, and particularly chronic lung disease, has been, services have been lacking across the continuum of care. We are now introducing things like spirometry throughout our hospital system and our health centers across the country. So I think these are the kinds of things we have to do to make UHC work. These are the kinds of things we have to do for the NCDs. Because my colleagues from the Caribbean are on here, there are two things that I will end with. One, mental health. In Guyana, suicide prevention is critical. The Gateway program, providing counseling where people live within their home setting, within their community setting. We have reintroduced that. And school nutrition. We have begun to reintroduce nutritional programs within the schools. So there are a number of things that we have to do. The best by describing DCP3 must be an imperative for all of us. We are doing that. Let me end by asking all of us to join the advocacy. Too much salt, too much sugar in our food. We have to have some global harmonization in terms of letting people know labeling, package labeling is critical. These are all the things we're trying to do in Guyana, many more things, but we need to work together to make this work for our people around the world. Thank you.
Thank you so much, Dr. Ramsamy, for that. Francoise, if I could ask you just very briefly to touch upon that question around the community health workers and what sort of screening they're able to carry out at a community level.
Yeah, thank you so much. And let me start saying that these are really people that are trusted by their communities because they have really helped a lot to reduce the maternal and child mortality, malaria deaths, because now there are 6% of malaria cases they are treated in the community by those community health workers. So recently for NCDs, we've increased their package to add NCDs awareness, NCDs screening, but also NCDs follow-up. Because we do have 4 people in a village, 4 community health workers in a village. So, and a village has got on average 250 households. So meaning that each community health worker has got around 60 households under his or her catchment area. So they are in charge of really making sure that they are the ones that are counseling, that are supporting their communities in different matters related to health. So now we've trained them using their supervisors, because at each health center we have someone who is in charge of community health workers. We've trained them on this new package, and then they go back and train those community health workers under the catchment area of the health center. We've also defined a kit for a community health worker at each village. It's a kit, it's really a bag, a box with a blood pressure machine, blood sugar machine, with strips, but also a weighing machine, so that those community health workers can go village per village, house per house, just to screen those eligible people, and then the priority is being given to people above 35 years old. So mainly they're focusing, their screening is mainly on blood pressure, but also blood sugar, but also they're taking, body mass index, and they be able to counsel people accordingly, but also teaching them about these major NCD risk factors, tobacco and alcohol. And also, they are no longer using papers. We've now provided them with gadgets, mobile phones, smartphones, but also tablets. And then we've also now, digitalize those services that they are providing in the community. So they screen and enter data into their tablets, and then be able now to refer those people with abnormal measurements to the health center, so that they can go there and confirm the diagnosis, and also be able now to initiate the treatment. But also on top of that, because our people go to their facility once every month for pharmacy refill, but also to check on their blood pressure, and also sugar if they are diabetic. But we are seeing that as the numbers are increasing, maybe it will be a very huge burden for the health centers to have all those people every month. So we are now thinking about, how for those people controlled, people with a good adherence, a good understanding, how can we give them drugs for 3 months? And then they come back once 3 months to pick the drugs. And this will also help to save on the transportation. But we think that in between, they can go to those community health workers once a week to check on their blood pressure, their blood sugar, and then be able to report those numbers through the digital platform that they do have to the health centers. And if there's something really alarming or very abnormal, the patient can go back to the health center. So this is what we are doing, and we've started, I think, 8 months ago. We are really following it very closely, and what we are seeing is that really, the numbers are increasing quickly, and we are really looking at this initiative as something that will help us to increase awareness, increase early detection, but also increase treatment outcomes for our people living with these major NCDs. Thank you.
Thank you so much, Francoise. And Kirsten, just the final word from this panel for the UHC high-level meeting in September and the political declaration. What are your top 2 to 3 priorities from an NCD perspective? Oh, maybe we've lost Dr. Petric. Are you still online?
I am here. I just didn't realize I didn't put on the microphone.
Great.
The 3 things that I would see as very important are that if we want to have any progress in globally, we do require international solidarity. And here I'm not speaking only of funding, I'm also speaking of being able to exchange good practices between the countries, being able to share innovations and develop one if necessary when approaching all these new challenges in the NCDs, but also more broadly. I think that we should aim to get more funding in the WHO for the NCDs. It is obvious that, when you have emergency situations, there is much more willingness to invest than when you have some more chronic problems. There, it's more difficult to make sure, that we ensure enough funding to progress as we would want to. The second thing that I would want to be discussed in New York is, that WHO is our key organization in implementation in particular. And the focus on the country level, as it is promoted just now by WHO leadership, is essential if we want to implement. We have to increase technical support to the countries in need, so that they would be able to strengthen their programs and their capacities on the ground. The third thing, and here I'm also answering the fourth question from the chat, are the NGOs. We have to be very clear of the role of NGOs in all of this. I have spoken a little bit in my intervention about how NGOs are very important to be able to reach the most vulnerable. In particular, this is so in the areas where, you know, we have crises, we have war areas where it's very difficult to address the needs of population because international organization cannot even enter those areas sometimes. And there we should be able to work better with the NGOs that are there and that are entering these areas and try to work with them appropriately to make sure that they are contributing to the work there and to be able to ensure access to health services also for these populations. I think this is really crucial. If you ask me, role of NGOs is crucial in two ways. One way is that they are the ones that can address, access first the needs of populations, of the vulnerable populations where health sector maybe cannot. And they're also the ones that can then ensure that the services are brought to these populations if for these people or these populations, it is not easy to access services that are available in health centers. So there are two things that NGOs can do. They can, of course, also promote preventive services, for example, to us. All of this, I think, will need to be discussed in New York.
Thank you so much, Dr. Petric, and thank you for doing what I normally have to do in these events, which is reinforcing the role of NGOs. So thank you very much for that really eloquent explanation of the importance of NGOs, both in terms of access to services, as well as, you know, social participation in helping shape policies, decision-making, as well as helping to shape how health services should look from a patient perspective, essentially. So thank you so much to our four panelists for that really great discussion around the challenges of NCDs and really concrete examples of how countries are taking forward universal health coverage from an NCD perspective. I'm not doing an excellent job of time management for this event, so apologies. I think we're going to be having to go to about 12:30. So now we'll switch gears from panel 1 to panel 2. And I'd like to invite Kaiser and Akihito to be joining me up on the panel, because for this panel, we have a mixture of live participation as well as virtual participation. So we're shifting gears from what government's doing around UHC and NCDs to panel 2, where we'll be answering the question, how can we work towards progressive realisation of universal health coverage for people living with NCDs? Our first speaker is Ms. Kaiser Limburg, who's a lived experience advocate and a former member of the NCD Alliance's advisory committee for the Our Views, Our Voices initiative that promotes the meaningful involvement of people living with NCDs within the response by enabling them to share their lived experience. So Kaiser, I have a couple of questions. Firstly, how can we engage people living with NCDs to keep UHC truly people-centred?
Thank you, Katie, and it's an honor to be here, and as always, to work with the NCD Alliance, as well as the other co-hosts. I should start by saying that I'm a person with lived experience of several NCDs, and I was lucky to be born in a country where we have UHC, and that has made all the difference for me. It has helped me survive brain cancer. It has helped me survive type 1 diabetes, as well as a half a dozen other NCDs and cancer complications. So for me, UHC has been fundamental. Without it, I'm pretty certain that I would be ruined somehow. You know, I would be indebted for life, or I would be even be dead. So I know firsthand the importance of UHC, and I think the involvement of people living with NCDs in this fight, or in general in the health sector, has been neglected for very long, and instead we have let, or other people have spoken on our behalf with varying degrees of success and accuracy and respect. And I think that involving people with lived experience makes this fight more urgent, it makes it more effective, and it makes it more relevant. And you touched upon this, but you know, also because it is not an isolated event, NCDs. It's something that affects our everyday life, even beyond the medical parts. It's something that a lot of us are living with several NCDs, meaning that, you know, integrated care is an important aspect that we maybe haven't looked so much at before. And obviously, UHC is not only important for global health, but it's important, you mentioned this as well, it's important for, you know, the fight against poverty, the fight for gender equality, for social justice and human rights, for sustainable development all over the globe. And I think that in order to bridge this gap, we need to understand what people with lived experience, people with NCDs experience in their everyday life. We need to understand their challenges. And the only way we can do that is by letting us speak for ourselves. And I think I talk about this a lot, but people with lived experience, we are experts in our own right. Our expertise is different maybe from a lot of the other stakeholders at the table, but it's very much an expertise, and it's an expertise that should be acknowledged and should be respected and shouldn't be treated any less than the other expertise at the table. But I also think that it's important to understand that people with NCDs are more than just their condition. We are often really good at telling our stories. It's something that we do a lot, and we help humanize the fight for NCDs and the fight for UHC. But I do think that it's important that we bring different perspectives to the whole issues, and people with NCDs are more than just storytellers. I've said this before, so apologies if you heard me say this, but I think it's important. You know, we're good at telling our stories, but we're more than that. We're also professionals in our own right. We're lawyers and nurses and teachers. We're analytical, we're strategic, we're visionaries and doers and everything in between. And I think that, you know, we represent all of society, including having NCDs. So I think it's important for us to utilize that. We have experience beyond simply our NCDs. And I think it's critical to utilize that. And I think there are factors that are necessary for us to be able to do that. The first is a political will to include people with NCDs. And oftentimes I find that stems from an understanding of the issue. And that is often the human aspect from getting that aspect, from understanding why it's important that we involve people with NCDs. And another is supportive organizations. And I'm always the first to highlight that the NCD Alliance, to me, is very much this organization. The third one, which can be a bit tricky to talk about, is also capacity development of people living with NCDs. We are experts in our own right, but we might not be used to being at that specific table or being in that specific setting and helping people feel comfortable, helping people get their message across. See, I'm struggling with it now. Helping people get their message across in the best way, I think, is important as well in this fight. And the fourth one I would say is resources in general, helping people to actually be able to be at the table, definitely, and financial resources. And so to me, I think as someone living with NCD, someone with experience, as an advocate and as a professional as well, I look forward to helping set a new standard and to systematically ensure that people with NCDs are included in this, not just as a tokenistic gesture at the end, but very much from the beginning, from already in the planning processes as experts, and in a way that is hopefully institutionalized on you know, a local, a national, and a global level.
Thanks, Kaisa. And I think, yeah, absolutely, kind of, as you say, in a way, UHC doesn't have a face. And so putting a face to the universal health coverage agenda is so important. And that's what people with lived experience can so strongly do, as well as you say, absolutely, people living with NCDs, affected communities, essentially being experts in their own right and being recognised for that by governments, by the World Health Organization, all different stakeholders. So important. Let me bring in Akihito now. So Akihito is the program manager for UHC 2030, has a very big and busy job this year with 3 high-level meetings on health happening this September. A massive challenge from a kind of coordination perspective and understandably from a government perspective in negotiating these 3 high-level meeting declarations in, side by side. So Akihito, how can we align the global health and development priorities to achieve universal health coverage? And why is this important for implementation of UHC?
Thank you very much. So first of all, thank you for inviting this meeting, this event. And also I'm working on universal coverage as a whole, as a partnership. Also, I'm coming from NCD and health promotion prevention work, but my first career in public health was Minister of Health in Vanuatu, working on a health promotion prevention financing. That's also I faced a lot of challenges, how to increase the funding for NCDs, how to maintain the preventions and promotion services. That's also my background coming from to focus on the UHC agenda. So in terms of the high-level meeting next this September, we need that the government recognize that we need to act on the fact that development and health the priority should be highly interconnected. That we can't address the single issues one by one in the head of states level. So we work together with a multi-stakeholder partner to identify the action agenda that we can put on the table for the negotiation of the high-level meeting. So the UHC 2030 with a partner, with the different partners, we are going to launch the action agenda from the UHC movement, which we are going to launch 27 March, next Monday. So this is already available. This is the skill embargo version, but we are happy to show more detail later. But so this is the action agenda from UHC movement that I'm happy to share the outline of the 8 action area, which is very similar to the one that we prepared 2019, which covered 6 cross-cutting agenda with gender equality. So this time we have 8 agenda, which include a connection between universal health coverage and health security, which is also critical lesson learned from COVID-19, how we emphasize more prevention and the public health functions, which is also critical for NCDs, not only infectious disease, but we need to make sure that public health and then the preparedness to be part of the health security, part of the health systems, because we can only address all different issues as part of the one health system, not the different health system for the different disease or different program. And of course, we focus on the champion, the political leadership for universal coverage, which is very similar to the previous higher meeting agenda. And then the leave no one behind, which is critical in health equality agenda for the universal coverage. And then law and regulations, and also specific more focus on health workforce, which is also critical part to deliver health services, including the quality of healthcare services on prevention and promotion. And then investment and invest better and invest more, which also we put the specific spending targets on health, which have a strong the advocate from civil society to include some sort of target, and hopefully government could include. And so that is one also recommendation. And then particularly for the partners, multi-stakeholder partnership, we work together with a different stakeholder, including civil society, private sectors, and academia, and any part of the governments, not just the Ministry of Health, but finance, and also the protections and different group. We also prioritize this moving together and across multi-stakeholder, but also multi-sectoral engagement, which is also important for NCD approach, I think. And the gender equality in health, that we keep this priority, particularly not not just the gender-related services, but also the women's leadership in global health and also the health sector. That's also our priority this year. And we are happy to provide more details next Monday. And also we are planning to organize the webinar with the NCD Alliance and other partners, for example, in partnership on 30th March to prepare the multi-stakeholder hearing this year.
Thank you so much, Akihito, and thanks for giving us the advanced view of the action agenda from UHC 2030. And just to flag, I mean, there's obviously a lot of milestones coming up with the UHC high-level meeting process, including the UN interactive hearings that are happening in New York on the 8th and 9th of May. So that webinar that Akihito just mentioned on the 30th of March will be giving more information of how those health-related hearings are going to be organised in New York. So now I'll come to Bente Mikkelsen, who is, I hope, online with us as well. Bente needs no introduction. She's the NCD director at the World Health Organization. And Bente, I mean, we've heard a lot from the first panel of these fantastic examples of how countries are implementing UHC from an NCD perspective. Can you give us examples of where you're seeing countries accelerating UHC implementation from an NCD perspective, as well as the types of support and technical assistance that countries are asking for from WHO on NCDs and UHC? Over to you.
Thank you very much, Katie, and it's been excellent to be co-organizing this very important webinar with the NCD Alliance and all partners. And it's great to see that the partnership is really growing. So it's been said, and I think we have heard different aspects. First of all, I can tell you that the integration into primary healthcare and UHC for NCD was the most requested support from countries when we did the planning for the last biennium. So that's very saying. And I think it's not, by chance, but it is really that the COVID-19 showed us the weakness of the health system, and that all these kind of disease areas, but also the prevention areas that is lagging behind, had such huge disruptions, which also led to excess mortality. And we have seen data recently that really confirm that it is also among the excess mortality, we see the NCDs and the different diseases, including oral health and rehabilitation as well. So I think your question is, what should we do now? We have only a few months left for the next high-level meeting. And I am so pleased to see all the different activities. Yet there is a lack of clear language seen from an NCD perspective. I think we have to be very clear. There cannot be any preparedness without NCD into UHC. We need to avoid what we see both during pandemics and humanitarian crisis. So I think that perspective of health security needs to come very strongly into the recommendations, the resolutions, the zero drafts. So I think this is a call for all of us. The other thing is, of course, the inequity perspective and the catastrophic expenditures and the poverty that is driven by the lack of inclusion into UHC. This has to be addressed, and it has to be addressed properly. We have to remind the world that 74% of all deaths is actually due to non-communicable diseases. So it's not a silo, it is the major sort of part of any health system. And if you ask family doctors, they say that NCD and mental health is up to 90% of all health system challenges. It is where the health system needs to respond. It was I was very pleased listening to the deliberation during the executive board, and thank you also to our eminent president of the EB, who really put, I would say, fresh air and opportunities for a bold discussion. almost on any item discussed, the member states raised the issue of NCD into primary healthcare and UHC. And this is not because nobody has told them to do so, but it is, of course, their felt need from the emerging epidemics of NCD. So I think I will stop by saying that we do a lot of technical work. We ensure that we have inclusion of NCD mental health into universal health, the universal health compendium. We also work on essential packages on the ground in the funded countries that we work in. And we continue to develop technical products. You will very soon see a technical product called Integrating NCD into Primary Health Care, together with malaria, HIV, TB, maternal and child health. We will launch that very soon. There is also other technical products. There is modeling going on. It is the packages and the renewal that comes through the new Appendix 3 renewal. And we are full on trying to get more support for real implementation on the ground, which was also mentioned in the formal panel. I think I will stop there. Thank you.
Thanks so much, Bente. Hopefully we'll have time for a quick round of questions. And obviously those here in the room, please start thinking about your questions. So finally, we'll come to our last speaker of this panel, Michaela Cecchini, who is the head of public health at OECD. Thank you for joining us virtually. I think obviously over the last hour, we've been hearing a lot about the challenges around health financing within universal health coverage. It's a challenge, particularly from an NCD perspective. And I understand that the OECD has recently calculated that member countries should invest an additional 1.4% of GDP annually to strengthen their health systems. Could you tell us how this additional investment should be spent and how this funding would help achieve universal health coverage?
Hello, everyone. Let me start by saying that both personally as an OECD, it's a pleasure to be here with you today and contribute to this debate on one of the top challenges, but also priorities that we have ahead of us, which is achieving universal health coverage. As you say, Katie, we calculated that member countries should spend an additional 1.4% of GDP relative to expenditure in 2019 to strengthen their healthcare system and achieve universal healthcare coverage. Our analysis suggests that these additional resources need to be invested on three overarching priorities. First, workforce to deliver high-quality healthcare services. Second, infrastructure. And number three, public health. I'm very happy and pleased to see that some of the comments that have been posted focus clearly on these three priorities, in particular when it comes to workforce. Out of the 1.4% of GDP that we think countries should spend on the top of what was spent in 2019, about half of this money should be devoted to the workforce. More workforce and better paid workforce. Improving access to care, especially for poor, through universal healthcare coverage is not enough if to achieve a better health outcome if we don't improve also the quality of the healthcare services that are provided. For high quality, we mean right care at the right time, in the right place, and by the right care provider, while minimizing harm and resource waste and leaving no one behind. Now, having a sufficient number of well-trained, motivated human resources is one of the crucial components in improving access. Fundamentally, in other words, we need gowns and overshoes on the ground to ensure that universal health coverage is achieved. Despite the record high number of healthcare workers across the OECD, we calculated that we need at least an additional 3 million more health and long-term workers to improve the health system resilience and strengthen the healthcare system in the coming years. In particular, primary healthcare is certainly the priority when it comes to universal healthcare coverage. At the OECD, our view is that there are some cross-service integration, patient-centered are two essential components of any strong primary healthcare system that supports achieving universal healthcare coverage. We need to invest in training programs to teach health professionals the new skills and supporting new professional roles, as well as we need to adapt the integrated care models that we have currently in place to the needs of the most vulnerable population. And we need, of course, to invest in health literacy. So 0.7%, we said, of the GDP on workforce. Then we need 0.4% of GDP to invest in infrastructure. Of course, we need a sufficient number of points of access to care, and we also need to bring this point of access of care closer to the patients, where there are the needs of the patients. We also possibly need to avoid the patient use a hospital as much as possible, because this is a very costly way of providing care to the patients. Of course, those in need should have access to the hospitals, and of course, trying to keep away from hospital those that can be treated outside hospital makes available additional resources for those that really need access to hospital. Across OECD countries, a priority is also to invest in digital tools and health information system. Looking at the findings of our study on promoting best practices for integrated care, we conclude that implementing digital inclusion activities targeting vulnerable population, as well as promoting digital tools and health information system, is one of the most efficient ways to move forward. The last point I would like to make is for public health. That accounts for the remaining 0.3% of additional GDP resources that should be invested. Let's face it, public health prevention is the Cinderella of our healthcare budget. Across the OECD, less than 3% of budget is spent on these crucial components, and we need to invest more on this component because it's a very efficient way to promote universal healthcare coverage, as well as maintaining a healthy population. I stop here for now.
Thank you so much, Michaela, for that really clear call around kind of extra investment from governments, the 1.4, and then how that breaks down across health workforce, infrastructure, and public health. Now I think we'll move on to the kind of Q&A section for this panel, and would like to open it up both to the audience here in Geneva. If you have a question for the panel, we've got a couple of questions that have come in from the online segment as well, but I wanted to give an opportunity for the Geneva audience first, if you had any questions. Yep, sure.
Thank you very much for the invitation. I'm Antonio from the Permanent Mission of Mexico. So thank you very much, NCD Alliance, for organizing, and thank you for all the panelists. As we're moving towards the high-level meeting on UHC, and it has been said, we have a short time towards that. What would be your key asks for member states regarding priorities that you have identified that should be included in order to improve the UHC declaration?
Thanks very much. So I might repeat that question in case the online audience couldn't hear. So a representative from the Permanent Mission of Mexico has asked, obviously with only 6 months until the UHC high-level meeting and the political declaration negotiations starting imminently, what would be the key asks from the NCD community for the UHC political declaration? So I open it up to the panelists. Obviously, anyone in the room or those online, Bente or Michaela?
I can start because, you know, as a Secretariat of WHO, we don't give advice to member states because it's really their prerogative. So I think this question is for the rest of the panelists and yourself, Katie.
No, I mean, I could start and then perhaps others can join in as well. Today, as part of this event, the NCD Alliance is actually formally launching our advocacy priorities for the UHC high-level meeting, which is this document here. And essentially, we have 4 main priorities. Number 1 is around investment in the prevention control of NCDs through adequate, predictable, and sustainable resources for UHC. which very much builds upon a lot of the comments that have been made already about the importance of strengthening financing, and particularly the financial risk protection and coverage part of UHC. Number two, it's around accelerating implementation of NCD prevention and care within UHC health benefit packages. And as many speakers have already highlighted, obviously the best buys of WHO being the main guiding document about what countries should be implementing within NCDs. Number three, it's around aligning global and development priorities to achieve universal health coverage, obviously ensuring that UHC is really a catalyst for cooperation across the global health community. And number four, very much building on Kaiser's point earlier around the importance of engaging people living with NCDs within UHC to make sure that it's people-centered, and that can look across engaging people living with NCDs in affected communities within decision-making processes, within policy development, within service design and delivery, as well as within monitoring and accountability. So really ensuring that their role is across the board within the UHC response. Would anyone like to add in terms of other kind of advice around NCDs and UHC, or perhaps advice around advocacy from an NCD perspective within the UHC debate?
I just think it's so crucial that we see people within their context, see people with lived experience of NCDs within a context, because it's not just a medical condition, right? We are people living in a society, living in a community, and like you said, to align this fight for UHC with the broader sort of challenges we face as a global community. I think that's very important, and also to be able to engage people and to make it more relevant. So that's all I have to add.
I would say so the high-level meeting is the head of states level meeting. It's not health ministers level meeting. So the benefit package, that is primarily the responsibility of the Minister of Health to identify what services should be included as part of the health budget. They can deliver the services. But beyond that, especially this multi-sectoral approach and also prevention and promotion, that is sometime beyond the Health Ministry's budget. And that is something that head of states can commit. And especially lesson learned from COVID-19. I think one of the highlight is health security and the public health prevention, how we include this part as part of the health systems. So I think that would be a very important element we should promote in the higher meeting this year. And of course, we can't ask a lot of things to the head of states, so we need to prioritize what is the critical elements that head of states can intervene and then make a commitment, and then delegate the health ministry to also work on the more details.
Thank you, Akihito. And let me just bring Michaela in one more time, because we've had a question from Paul Mendoza online, who is asking, what are the strategies to encourage governments to look at health financing, particularly for NCDs, as an investment rather than a cost?
Thanks, Katie. I also take the opportunity, because I did raise my hand to respond also to the first question. So I take the advantage of this, and I'll get back to you. In terms of priorities, from my point of view, I would see three priorities. Number one, the financing and the funding. Our work has calculated the amount of extra funding that is needed. Of course, it varies across countries, but ensuring a strong commitment on funding and financing is key. Number two, is on public health prevention. It's not just managing the NCDs, but also closing the tap, as it has been said many times, and this provides a super useful contribution. But I say a little bit more on this in my second answer. And number three is not just focusing on the coverage, so increase of the coverage, but also on the quality of healthcare is provided. Quality is crucial, is fundamental to improve the health outcomes. It's not just giving poor services to more people that is sufficient. Now, getting to the second question, how we can make the point? Well, both OECD and WHO, sometimes working together, we, I think, have a strong commitment in helping countries making the point, helping ministries of health making the point that investing in public health, investing in prevention is an investment in the wealth of the country. Just to give you a few examples, we calculated that the return on investment of some of the most common intervention to tackle an healthy lifestyle, whether it's physical activity, diet, tobacco, harmful alcohol consumption, have a return on investment of $16 for every single US$ invested when you look at the broader impact of this intervention, not just on healthcare expenditure, but also on workforce productivity, for example, and the broader economy of a country. So that's a very strong argument that Ministry of Health, but it's also very important to strengthen liaison with non-governmental organizations, with other stakeholders to make this economic case for health. Now, there is another point that I would like quickly to raise, which is we are today focusing on NCDs, but believe me, infectious diseases have a significant impact as well on achieving UHC for NCDs. In one of our most recent analyses, we calculated, for example, that across 34 OECD and the EU countries, every year, 32.5 million extra days are spent in hospitals to treat the consequences of infections, resistant infections that are acquired in hospital, people that most often had a chronic disease, they were in the hospital to treat a chronic disease and then had to spend extra days in hospitals to treat the consequences of infection. 32.5 million extra days across 34 OECD countries is a huge amount of resources, both physical resources but money that is spent to treat things that in an ideal world shouldn't be spent. So that's something we need to take into account, and better infection prevention and control would provide a significant support to achieving UHC. I stop here.
Thanks so much, Michela. And I think, yeah, also the point about in terms of making the case for investment, it's also important to be talking to our ministers of finance as well, who obviously hold the purse strings on government budgets. Bente, I'll give you the last word and then we'll have to wrap up.
Okay, that's an honor. So thank you very much, Michele. I think having facts on this is so important because this was my point as well. I think we need to work at least, on 3 different approaches. One of them is, of course, to increase the domestic funding for NCDs. And I think the work we do on essential benefit packages is excellent, but we see in many countries that it's a little bit of a fairy tale. There are priority setting, there are inclusion into plans, but when it comes to the real priorities, according to the fiscal space, it's not really combined. So it's not enough to show the cost. It's also important to really look into the social security system, the insurance system, and to match these 2 things. And we do that more and more, and also to use the system of health technology assessment. So that's one. But the other one is, of course, that many countries can never, ever do this without the infusion also from the international funding. So I really loved your interventions, Michele, because what we are trying now is to really make a case on the ground for the Global Fund, for the World Bank. And we are really now working systematically together with our communicable disease colleagues to utilize these changes in both perception, but also strategies from the different, I would call them old financial institutions that was set up only for communicable diseases, but is now sort of working on the reality that we need to look at this together and strengthen the health system, especially at PHC level, but in general, together. So I think that's, and we also have to never forget when we speak about UHC, we need to also speak very, very loud on prevention and health promotion. It was not mentioned too much today, but I think we all know it on this call. So let's not forget that the best way is actually to prevent well, and then we have to mitigate the consequences of not being able to be close to that mark. So thank you very much, Katie.
Thanks so much, Bente, and thank you to all of our speakers on that last panel. And as Bente said, I think it's really promising that we're seeing global institutions like the Global Fund and PEPFAR beginning to come into the space of integration and integrated people-centered services, which is so important. So thank you again for all joining us, and apologies for the lousy timekeeping from the moderator. I think just to end, I think I would just like to underscore that, 6 months until the UHC high-level meeting in September, very short space of time, and we have to make sure that it counts for people living with NCDs. We mentioned earlier the interactive hearings that will take place in New York on the 8th and the 9th of May, really important from a civil society and all stakeholder perspective to be ensuring that we're singing from the same song sheet and really emphasising similar messages around the importance of NCDs within UHC. And I had an opportunity, thanks to our colleague from Mexico, to already share with you the NCD Alliance's advocacy priorities, which very much are meant as a complement and a support to the UHC action agenda that Akihito mentioned earlier as well. So lastly, I'd really like to thank again our co-hosts for this event, the Permanent Mission of Guyana and Rwanda, the World Health Organization and the Helmsley Charitable Trust. A very warm thank you to all of our panelists, both virtual and in person, for joining us today, and also to our audience here in Geneva as well as online. Great to see, even though we've gone over so much, still got 70 people online, which is great. Just finally, before we close the session, I invite you all to watch a very short case study video of how Thailand has been integrating oral health within universal health coverage. And this is one of a series of case studies we'll be launching in the lead up to September. So let's take a quick look. Thank you again for joining us, and have a good rest of your day for those online. And for those in the room, please join us for a lunch at the back. Thank you very much, everyone.